Perhaps it's difficult to imagine in this age of technological achievement that pregnancy is an exciting experience for any woman, but indeed it is. For a woman having her first baby, it is a very exciting experience, not only for herself but for her husband and her immediate family. The development of the baby commences at the time of fertilisation, which actually occurs some 14 days before the woman misses her menstrual period. Ovulation occurs about the middle of the menstrual cycle, about day 14 of the menstrual cycle. The ovum is only capable of being fertilised for a few hours after it's released from the ovary, so fertilisation occurs about the middle of the month. The sex of the baby is determined at the time of fertilisation. It depends upon the sperm which fertilises the ovum. If it is a male sperm, one which carries Y chromosome, the baby will be a male. If it is a female sperm, one which carries an X chromosome, the baby will be a female. By the time the woman misses a menstrual period, she is already 2 weeks pregnant. By the time that the modern tests can tell whether she is indeed pregnant, can confirm it for sure, she's about 3 to 4 weeks pregnant. So when she goes along to the doctor and she's, say, 2 weeks over a menstrual period, she's already 4 weeks pregnant. Now the duration of pregnancy is 280 days from the first day of the last menstrual period, which is approximately 9 calendar months. The weight of the baby varies, of course, during pregnancy, as one would expect. It starts off as 2 minute cells, the ovum of the mother and the sperm of the father. And it ends up some 40 weeks later weighing approximately 7.5 pounds or 3,500 grams. Of course, some babies are larger than this and some are smaller. At the 12th week, that's the end of the 3rd month, the baby is 3 inches long. 4 weeks later, at the 16th week, it's 6 inches long, it's doubled its length. At the 20th week, it's 8.5 inches long. At the 24th week, it's 12 inches long. At the 28th week, it's 14 inches long. At the 32nd week, that's 8 weeks before the baby is born, it's 16 inches long. And then you get a dramatic increase in size. At full term, it is about 20 inches long. And in the last 8 weeks, the weight of the baby doubles from 3.5 pounds to 7.5 to 8 pounds. And that is why a premature baby is much smaller. Even if it's only 4 weeks early, it's much smaller than a full-term baby. In the early weeks of pregnancy, the mother can suffer some symptoms of discomfort. The commonest, of course, is morning sickness. Some women don't suffer from any morning sickness at all. Others do feel a little off colour in the morning. They feel squeamish. Some vomit, and indeed some others have very severe vomiting and repeated vomiting every morning of the first 3 months of pregnancy. Fortunately, morning sickness usually completely disappears by the end of the 3rd month of pregnancy. The real cause of morning sickness is unknown. It's thought to be due to the hormones of pregnancy, but why some women get it and others don't get it is not known. Frequency of micturition is one of the other common symptoms of pregnancy. Women notice that they have to go to the toilet more often to pass their urine, and this is one of the early signs, although it is not specific of pregnancy, but taken together with morning sickness, it is a very reliable sign of pregnancy. In the latter months of pregnancy, indigestion is one of the common symptoms. It is not common in early pregnancy, but from the middle of the pregnancy onwards, from about the end of the 4th or 5th month, this is when women suffer most from indigestion. Of course, they can have indigestion remedies, tablets, powders, to relieve their discomfort. The actual cause of the indigestion is not known. It is thought that it may be the pressure of the baby on the stomach and intestines which causes it, but the actual cause is not known. Of course, women suffer from pains in the legs and in the back during pregnancy, and if you just look at a woman in late pregnancy, you can see the way her tummy's come forward and her back goes backwards. She assumes a more upright posture, and this does put a strain on the ligaments of her back, and thus causes backache. She will perhaps develop varicose veins during pregnancy, and this will give her some aching pains in the legs. So these are some of the common discomforts in the latter months of pregnancy. The breasts undergo enlargement during pregnancy. The weight increases in the breast and the size of the breast increases. Vaginal discharge is common in the latter months of pregnancy. Of course, bleeding can occur in early pregnancy due to a threatened miscarriage, but this is different from the yellowish discharge which accompanies late pregnancy. Unfortunately, bleeding in early pregnancy is always a sign of threatened miscarriage. It may not go on to a miscarriage, of course, but women should treat bleeding in early pregnancy as a serious warning of threatened miscarriage, and this should be treated with bed rest and perhaps sedation. But rest is terribly important, that they should go to bed for at least 3 days if they have bleeding in the early months of pregnancy. About the middle of the pregnancy, the baby starts to move, and this is commonly known as quickening. This occurs about the 18th to 20th week of the pregnancy. Some women who've had previous pregnancies can recognise quickening much earlier than this, but a woman experiencing her first pregnancy usually detects the baby moving about the 18th week. At first, the movements are very gentle, and some women describe them as a very gentle flutter, as if you were holding a butterfly or a little bird in your hand. The diet of pregnancy should be adequate in protein, at least 100 grams of protein a day, and to obtain this you should have at least 1 serving of meat or fish each day. At least 1 good serving of meat or fish. Of course, other good sources of protein are eggs and cheese, so that 100 grams of protein is the minimal amount in pregnancy. It is advisable to avoid excessive intake of food, particularly in carbohydrates, so the intake of cake, biscuits, things like that should be watched, because carbohydrates will give you a lot of calories without actually giving you bodybuilding protein. So that a good diet, a sensible diet, which includes at least 1 serving of meat or fish per day, adequate vegetables, at least 2 pieces of fruit a day. But remember, excessive amounts of fruit contain large amounts of sugar, and this is a form of calories and will put on weight. But 2 pieces of fruit are adequate for the intake of vitamins in pregnancy. Milk is important in pregnancy because it is the best source of calcium that the mother can get. Some women, of course, don't like milk, and indeed in some it upsets them. So in those cases, a woman should take calcium tablets, at least 4 tablets each day. But if she likes milk, as the majority of women do, a pint of milk per day is an adequate intake of calcium, and it is also a good source of protein and some fat. If she's worried about her weight gain, skim milk is just as good a source of calcium as whole cream milk. Exercises in pregnancy, I think, should be done in moderation. Squash, I feel, is too strenuous for the pregnant woman because it takes the blood supply from the uterus to the muscles of the legs. Competition tennis, I feel, again, is contraindicated because one tends to play perhaps a little harder than one should, and also one is obliged to go along and play even if they're not feeling well. Whereas social tennis, I think, is perfectly all right in pregnancy because you're not obliged to play. The same thing as swimming, I think that's very good. Surfing, again, is perfectly all right in pregnancy, but one has to beware of other bathers because people coming in on waves can bump into one in the surf. But if you don't take those risks, it's perfectly all right. Calisthenics are perfectly all right in pregnancy. Some women do jazz ballet, which is a popular form of exercise these days, and any exercise class is perfectly all right. I think it's a good thing to tell the people running exercise classes that you are pregnant so that they won't give you any exercises which are too strenuous. Women can have intercourse in pregnancy practically till the end of pregnancy. The last 4 weeks perhaps it is contraindicated because there is a risk of rupturing the membranes during intercourse, but certainly until the last few weeks of pregnancy it's perfectly all right to have intercourse. The excessive intake of alcohol in pregnancy can cause brain damage to the child and cause mental retardation. 2 whiskies per day in pregnancy, which is 2 ounces of whiskey or its equivalent in gin, sherry or beer, are enough to cause brain damage to the child. And it is something which I think is important, that the alcohol intake is carefully watched, particularly in the early months of pregnancy. Smoking in pregnancy is controversial. Some authorities claim that it has adverse effects upon the child. In my own opinion, I do think it causes slightly reduced birth weight in the child if the mother smokes more than 10 cigarettes per day during pregnancy. I don't think it has any other ill effect on the child, but the birth weight may be reduced by as much as 4 ounces. So the baby will be slightly smaller in weight, but I don't think smoking has any other ill effect on the child. There has been a lot of talk about aspirin in pregnancy, and aspirin, if given in large doses to experimental animals, will cause congenital abnormalities in the offspring of those animals. However, aspirin can be taken in moderation by pregnant women. When I say moderation, I would say no more than 2 aspirins per day, and this is in the form of any of the commonly used aspirin preparations. Rest during pregnancy depends upon the individual. Some women work throughout their pregnancy and they don't feel tired, particularly if their husbands give them help with their household chores. Other women require more rest than that, particularly if they have any illnesses which are aggravating their pregnancy. Then it is wise for them to rest for at least 2 hours in the afternoon and again have 8 hours rest each night. So that the rest required by a pregnant woman varies from individual to individual, but certainly all pregnant women should aim at having 8 hours sleep each night. Air travel during pregnancy depends upon the airlines. Most airlines will take pregnant women until they're about 34 weeks pregnant, that is about 6 weeks before the baby is due. After the 34th week, the airlines don't like to take pregnant women in case they come into premature labour and the baby is born in the aeroplane where they haven't got adequate help, and it takes the airline staff by surprise. So that this is the reason that the airlines don't like taking pregnant women in the last 6 weeks of pregnancy. There's no danger to the woman or to the baby, but purely the fact that she may come into premature labour. car travel does cause fatigue. I think 250 to 300 miles in any day of travel by car is as much as any pregnant woman should undertake. A journey longer than that without a break of a night's rest I think is too long. But I think up to 300 miles a day with a night's rest is perfectly safe. Sea travel is perfectly safe during pregnancy. Of course, most of the liners carry doctors, and so you've got no troubles there. The care of the teeth in pregnancy is very important, and a pregnant woman should consult her dentist when she's about 3 months pregnant. He will examine her teeth, then will correct any cavities which she may have developed or any caries. But if one takes a good calcium intake in pregnancy, it will help protect her teeth. The calcium deposits in the teeth and in the bone are not static. They depend upon our calcium intake, and so that is why it's wise to take an adequate calcium intake in pregnancy. Otherwise, the calcium will be removed from the woman's bone or teeth to supply the baby. And some women do complain that pregnancy has adverse effects on their teeth and that they develop caries during pregnancy. However, the majority of women don't suffer any adverse effects on their teeth in pregnancy. Every woman having her first pregnancy, when she goes to her doctor, will have her blood group ordered and her rubella titer ordered. Now, these things are both essential. Essential that we know her blood group so that we'll know if she's Rh positive or Rh negative, as well as her ABO blood group. It is important that we know whether she's had German measles, and this is demonstrated by her rubella antibody titer. If she has antibodies to rubella in her serum, then she has no need to worry about coming into contact with a child with German measles during her pregnancy. If she has no rubella antibodies, she is at risk during the first 4 months of pregnancy if she comes into contact with a child or an adult who is infected with rubella. Rubella was once a very serious cause of congenital abnormalities. In 1941, Sir Norman Gregg discovered the association between German measles, or rubella, in the first 3 months of pregnancy and congenital abnormalities such as blindness, deafness, and heart disease in the newborn child. These days, of course, young girls can and should be immunised against rubella. Most children have rubella in their school age years. However, some children miss out on having it, and it is wise for all girls when they reach puberty to be immunised against rubella. And if they don't have adequate antibodies in their serum before they have a baby, they should be re-immunised. But of course, some women don't have this test done before they become pregnant, and so they should have a rubella antibody level determined at the time of their first antenatal visit. So then we'll know the woman's blood group, her hemoglobin, that is how much blood she actually has, and her rubella titer. The hemoglobin is important during pregnancy because she should take iron supplements during her pregnancy. This in the form of iron tablets. Iron tablets do upset some women. Some women they cause constipation, in others they cause diarrhea. But it is preferable to take iron if one tolerates it. As regards the Rh factor, 80% of the population of European descent are Rh positive. However, approximately 20% don't have the Rh factor and are what we call Rh negative. The Rh negative woman, that is one who lacks the Rh factor, if she marries an Rh positive man, the child, the unborn child, will probably inherit the Rh positive gene from its father. Now, the child's blood will be Rh positive, and at the time of birth, some of the blood from the baby gets into the mother's circulation, and this acts as an immunising factor and immunises her against the Rh factor. Now, this doesn't affect the firstborn child, but it may affect the second or subsequent child. Now, not every Rh woman suffered from Rh antibodies. Only about 5%, 1 in every 20, developed Rh antibodies. But indeed, this was a major cause of complications in their subsequent pregnancies. But some 10 years ago, it was discovered that by giving Rh negative women some Rh antibodies at the time of the birth of their baby, these antibodies would destroy any Rh positive cells which got into the mother's circulation from their child, and thus prevent her from developing Rh antibodies. So Rh antibodies are given to women at the time of the birth of their baby, or if they have a miscarriage, and this prevents them from forming antibodies. So that the Rh factor, or Rh disease, has practically been eliminated from modern obstetrics. Unfortunately, some women who have Rh antibodies given to them still develop their own Rh antibodies, but this is a very small percentage. So the Rh factor only affects a very small number of women these days. If the Rh negative woman does develop antibodies, in her second and subsequent pregnancies, the babies may be born anemic with what is known as hemolytic disease of the newborn. And these babies will require transfusions or indeed exchange transfusions. And one of the recent developments in obstetrics is to find out before the baby is born by taking a small quantity of the liquor which surrounds the baby in the uterus and studying this fluid to see how badly affected the Rh positive baby is by its mother's antibodies. If the baby is severely affected, it can be given a transfusion while it is actually still in the uterus. This is called an intrauterine transfusion. And by the use of the intrauterine transfusion or exchange transfusions after the birth of the baby, it is very rare these days for babies to die of hemolytic disease. Some women observe that during pregnancy their tummy gets much bigger than those of other pregnant women who are approximately the same stage of pregnancy. And this may be because they have more than one baby in the uterus. Twins, of course, tend to run in families, and a woman may suspect that she has more than one baby in her uterus because of the family history of twins, either in her side of the pedigree or in her husband's side. So that twin pregnancies or multiple pregnancies do tend to be inherited. If her uterus continues to increase in size more rapidly than she would expect, her doctor will probably order an investigation to see if she has a twin pregnancy. This can be done by means of an X-ray or an echogram, which is the use of high-frequency sound waves to determine whether there are more than one baby in the uterus. Twin pregnancy occurs about 1 in every 70 pregnancies, but as I've just said, it is more common in someone with a family history of twin pregnancy. Triplet pregnancies is far less common. It's about 1 in 7,000 pregnancies, but of course it's more common these days because of the use of some of the fertility drugs. Toxemia of pregnancy is a word that is commonly used. What it means is an elevation of blood pressure in the latter half of pregnancy. It doesn't occur until after the 20th week of pregnancy. It causes the blood pressure to be elevated, and this may cause other changes in the woman. She may notice swelling of her fingers, of her feet. It's more difficult to get her rings on the fingers. Her clothes feel tight, and this is because of fluid in the tissues causing the swelling. When she has a urine tested by the doctor at her antenatal visit, he may detect the presence of albumin in her urine. If albumin is present in her urine and she has an elevation of her blood pressure and evidence of swelling of her fingers or feet, he may suggest that she goes to hospital for bed rest for 1 or more days. So that toxemia of pregnancy is something which is treated by bed rest and by drugs to increase the fluid output by the kidneys and thus reduce the swelling, and sometimes by drugs which will have an effect on the blood pressure. But bed rest is essential if a woman is suffering from toxemia of pregnancy. Amongst the rarer variations of pregnancy is the so-called ectopic pregnancy. Now, what an ectopic pregnancy is that it's a pregnancy which occurs outside the womb, and it is usually situated in the tube. For some reason, the fertilised ovum, instead of going along the tube and settling in the womb, decides to settle in the tube. So the tube tries to accommodate the fertilised ovum. It will expand, but then, like the rubber balloon, if it's over-distended, it will rupture. And this causes pain and some bleeding. The pain is usually severe, and it will be severe enough to take the woman to her hospital or to her doctor, who will make the diagnosis of an ectopic pregnancy. Fortunately, it is not common, but it is one of the important complications of early pregnancy. The ectopic pregnancy is always discovered by the end of the 2nd month. Normal labour, although it should start about the end of the 40th week of pregnancy, of course, can occur earlier and sometimes occurs later than that. So if contractions start before the 40th week, don't think it's not labour because you haven't achieved the 40th week of pregnancy. Labour doesn't always start at the 40th week. It can come early, and this point is most important. The duration of a normal labour in the first pregnancy is, on an average, about 12 hours. It is rare for a labour to last more than 24 hours these days. 12 hours would be about the average for the first stage of a normal labour in someone having their first baby. The contractions at the start of labour are not strong, and the interval between them is long. But as the labour progresses, the contractions increase in intensity, become more frequent, and are associated with some discomfort. The amount of discomfort associated with the contraction varies from individual. At the beginning of labour, the contraction may only last 10 to 15 seconds, but then as labour progresses, the contraction will last up to a minute. The interval between the contractions at the beginning of labour is anything from 20 to 30 minutes, but then at the end of labour, they start to come at every 2 to 3 minutes, so that labour intensifies as the contractions increase in strength and increase in frequency. The first stage of labour is the period in which the cervix or the neck of the womb dilates. It is normally closed at the end of pregnancy or slightly open, but in order to allow the baby to pass from the uterus to the outside world, the cervix has to stretch up to 10 centimetres in diameter. So imagine a hole 10 centimetres in diameter, and that is the size of the open cervix at the time of the baby's birth. Now, this dilation of the cervix is accomplished in the 12 hours of the first stage of labour. When the cervix is fully dilated, the mother will have a desire to push or bear down. The quality of the contractions now changes, and she will have a feeling that she wants to open her bowel because it's the baby's head pressing down on the vagina and on the front wall of the rectum. This gives her the bearing down sensation, and she will be encouraged by the nurse supervising her labour or by her doctor to bear down. The second stage of labour is much shorter than the first stage, and this is the time that the baby's head is actually passing through the pelvis. It takes about an hour in someone having her first labour and up to 30 minutes in someone having a subsequent labour. So the second stage of labour is much shorter than the first stage. Sometimes labour doesn't start spontaneously, but it is brought on by the doctor, and it is known as the induction of labour. There are several methods by which labour can be induced. These involve the use of drugs. The most commonly used drug is one of the pituitary preparations, syntocin and pitocin, or the prostaglandins. It may, however, follow the rupture of the membranes or the forewaters which surround the baby's head, and this is usually done with a small plastic hook or with a metal instrument. And this simply allows the water in front of the baby's head to run away, as indeed often happens as the first sign of labour occurring spontaneously. Spontaneous labour can commence in 3 ways. One is a show. A show of blood in the last weeks of pregnancy is the commonest sign of the commencement of labour. Secondly, it may start by the membranes rupturing, allowing some of the fluid which surrounds the baby to run away. Or thirdly, it can start by the onset of uterine contractions. So these are the 3 ways which labour can start. If labour is induced by the doctor, he may give a preparation to cause the uterus to contract, and so it will start then by uterine contractions. Or he may rupture the membranes, which allows the fluid to escape, and so starts labour. Or he may use a combination of these methods. He may rupture the membranes plus give something to cause the uterus to contract and thus start the onset of labour. The woman may be told at some stage of her pregnancy that the baby is presenting as a breech. This simply means that the baby's bottom or buttocks are down in the lower part of her uterus. Normally, the baby's head occupies the lower part of the uterus. Now, the baby very often assumes the breech position at various stages of the pregnancy. So don't be alarmed if the doctor tells you that the baby is presenting as a breech, because the baby very often will change its position later on in pregnancy. However, about 4% of babies decide that the breech position is more comfortable for them, and they don't change to the vertex position, so that the mother comes into labour with the baby still in the breech position. The breech position is one of the complications of labour. It may require that the mother have a caesarean section, or it will require that she have assistance at the time of birth. Spontaneous birth in the breech position is not common, and assistance is usually required. The first question asked by a mother after she's had her baby, is it a boy or is it a girl? The second question is the baby all right? Does it have all its fingers and toes? In other words, she wants to know, is the baby normal? Fortunately, the vast majority of babies are born perfectly normal. However, there is a small incidence of congenital abnormalities, and about 2 babies out of every 100 have some severe physical deformity which is detectable at the time of birth. What causes these deformities? Some of them are produced by the genes it inherits from either its mother or its father, and others, the causes, are due to the environment. Of course, thalidomide was given much publicity because it was a drug which was found to produce deformities in the unborn child. Rubella, German measles, also can cause deformities. So here we have 2 examples of one a drug and the other a virus infection causing deformities. This is why it is wise only to take medication which is prescribed by your doctor for you, and not something which was prescribed for someone else during pregnancy. It is wise to avoid children with infectious diseases. Although rubella is the only known infectious disease which can cause deformities, it's advisable to avoid infectious diseases if possible in pregnancy. Influenza in the early months of pregnancy is something which should be avoided. Unfortunately, it is not always easy to avoid, particularly in winter months with crowded areas. One is likely to come into contact with someone who has influenza. However, if you develop influenza in early pregnancy, you should take it seriously, and that is go to bed and stay there for at least 3 days. Not only in early pregnancy does this advice hold, it holds at any stage of a pregnancy. Influenza should be treated seriously and not as a mild condition where you try to carry on doing your household chores and or perhaps even go to work. Birthmarks. Many babies are noticed shortly after they're born, or perhaps in some cases not for some weeks after they're born, to have red areas in their skin. The commonest of these are over the eyelids, and these are known as birthmarks. Actually, they have nothing to do with birth. They're developmental in the skin themselves, and they're usually caused by prominence of the blood vessels in the skin. The majority of these birthmarks disappear, particularly the red discoloration in the eyelids. They usually disappear by the time the baby is 2 years of age. And I'm happy to say that most birthmarks disappear. However, some may require treatment by a skin specialist in the early years of a baby's life. We've talked a lot about pregnancy, but now let us experience the miracle of childbirth. Good morning, Mrs. P. How are you this morning?
Fine, thank you.
Good. Well, this is your big day. Although,
Mine.
not only yours, no, it's the whole family's big day. Father's here too. So your husband's waiting outside, so it'll be a big day for the three of you. The baby will come along later today. Now, you came into hospital last night. Did you sleep well?
Yes.
You slept very well, did you?
Till 4 o'clock and all the babies started to cry.
Till all the babies started to cry at 4 o'clock, I see. But you slept well until then. And you had a normal dinner last night?
Yes.
Good. But this morning they gave you a very light breakfast, I imagine, did
Yes,
they?
tea and toast.
Tea and toast for breakfast. Good. Right. Now this is your first baby, Mrs. P, isn't it?
Yes.
That's good. You've had a very uneventful pregnancy?
Yes.
Good. Good. Well, it's all coming to an end very shortly. Mrs. P, you're going to have your labour induced today because you are now 13 days overdue. So that in a few minutes I will scrub up, put on a gown and mask, and I'll rupture your membranes or break your waters, as it is sometimes called. This will allow some of the water which surrounds the baby to escape, and this will help stimulate your labour. We've already put a needle into your vein to put a drip up, and this drip will contain syntocinon, which will stimulate your uterine contractions. Later on, we will put the syntocinon onto a Cardiff pump, and we'll put a catheter, a plastic catheter, inside your uterus to measure the strength of the uterine contractions, and this will then, the strength of the contractions will control the speed with which the pump pumps in the oxytocin into your vein. And so this is a combined medical and surgical induction of labour, and you're now 13 days overdue, but I can assure you the baby will be born later on today.
Will it hurt?
No, it won't hurt. We'll ask you just to draw your legs up for a minute or two, and we'll examine you, and just like we did on the first visit to the surgery, and then we'll rupture your membranes.
Will I feel the contractions?
For a short time, but when they get stronger, we will probably give you an epidural block to relieve the pain. The contractions at first won't be very strong, and they won't have much pain associated with them, but once they start to cause you some distress, I'll have the anaesthetist put in an epidural block to relieve the pain.
Will the epidural block be painful?
No, the doctor will put a tiny little injection of local anaesthetic into your back, and he'll put a needle into the lower part of your back, and he'll put a very, very fine plastic catheter in through the needle, and he'll inject the epidural block solution through that. There'll be no pain associated with it at all. Hey?
Oh, yes, I think so.
Very good, very good. Now, it'll take a few days for you to establish lactation. For the first few days, some colostrum will come away from your breasts when the baby sucks, and it'll be about the third day before you get a good flow of milk, and your breasts may become a little sore at that stage. And of course, you may find that if you've got a lot of milk, that it may leak through the nipples from time to time and dampen your flow. Now, you have had a perineal shave earlier this morning, and we just shave a part of the perineum, but these hairs, of course, soon grow back.
How long does it usually take?
Just a few weeks after baby's born, and the pubic hair will soon grow again. Now, during the day, you won't be given any food or fluids to drink, so you'll have nothing by mouth. You'll be given all the fluids that you need intravenously. If your mouth becomes very dry, you can ask sister for some ice to suck.
When will I be able to have something to eat?
After baby's born, we'll give you a cup of tea and bread and butter, and then, of course, you'll have your first meal at the appropriate time. If the baby's born before lunch, which I doubt as it's your first baby, you'll be given lunch, or if it's born before the evening meal, but we won't let you go hungry.
Oh, thanks.
Now, when the baby's born, you'll probably find it's covered with vernix caseosa, which is a a creamy sort of material. It looks like face cream, and indeed some of the expensive face creams, they say, are made from this vernix. Now this has covered the baby for the 9 months it's been living in a watery medium, and it's protected the baby's skin, and some of the vernix will still be on the baby after it's born. So we will move you around into the delivery room in just a few minutes. Good morning, Mrs. P. How are you this morning?
Fine, thank you.
Good. Well, this is your big day. Although
Mine.
not only yours, no, it's the whole family's big day. Father's here too. So your husband's waiting outside, so it'll be a big day for the three of you. The baby will come along later today. Now, you came into hospital last night. Did you sleep well?
Yes,
You slept very well, did you?
till 4 o'clock when all the babies started to cry.
Until all the babies started to cry at 4 o'clock, I see. But you slept well until then. And you had a normal dinner last night?
Yes.
Good. But this morning they gave you a very light breakfast, I imagine, did
Yes,
they?
tea and toast.
Tea and toast for breakfast. Good. Right. Now this is your first baby, Mrs. P, isn't it?
Yes.
That's good. You've had a very uneventful pregnancy.
Yes.
Good. Good. Well, it's all coming to an end very shortly. Mrs. P, you're going to have your labour induced today because you are now 13 days overdue, so that in a few minutes I will scrub up, put on a gown and mask, and I'll rupture your membranes, or break your waters, as it's sometimes called. This will allow some of the water which surrounds the baby to escape, and this will help stimulate your labour. We've already put a needle into your vein to put a drip up, and this drip will contain syntocinon, which will stimulate your uterine contractions. Later on, we will put the syntocinon onto a Cardiff pump, and we'll put a catheter, a plastic catheter, inside your uterus to measure the strength of the uterine contractions, and this will then, the strength of the contractions will control the speed with which the pump pumps in the oxytocin into your vein. And so this is a combined medical and surgical induction of labour, and you're now 13 days overdue, but I can assure you the baby will be born later on today.
Will it hurt?
No, it won't hurt. We'll ask you just to draw your legs up for a minute or two, and we'll examine you, and just like we did on the first visit to the surgery, and then we'll rupture your membranes.
Will I feel the contractions?
Well, you will for a short time, but when they get stronger, we will probably give you an epidural block to relieve the pain. The contractions at first won't be very strong, and they won't have much pain associated with them, but once they start to cause you some distress, I'll have the anaesthetist put in an epidural block to relieve the pain.
Will the epidural block be painful?
No, the doctor will put a tiny little injection of local anaesthetic into your back, then he'll put a needle into the lower part of your back, and he'll put a very, very fine plastic catheter in through the needle, and he'll inject the epidural block solution through that. There'll be no pain associated with it at all. Are you going to breastfeed, Mrs. P?
Oh, yes, I think so.
Very good, very good. Now, it'll take a few days for you to establish lactation. For the first few days, some colostrum will come away from your breasts when the baby sucks, and it'll be about the third day before you get a good flow of milk, and your breasts may become a little sore at that stage. And of course, you may find that if you've got a lot of milk, that it may leak through the nipples from time to time and dampen your clothes. Now, you have had a perineal shave earlier this morning, and we just shave a part of the perineum, but these hairs, of course, soon grow back.
How long does it usually take?
Just a few weeks after baby's born, and the pubic hair will soon grow again. Now, during the day, you won't be given any food or fluids to drink. So you'll have nothing by mouth. You'll be given all the fluids that you need intravenously. If your mouth becomes very dry, you can ask sister for some ice to suck.
When will I be able to have something to eat?
After baby's born, we'll give you a cup of tea and bread and butter, and then of course you'll have your first meal at the appropriate time. If the baby's born before lunch, which I doubt as it's your first baby, you'll be given lunch, or if it's born before the evening meal, but we won't let you go hungry.
Oh, thanks.
Now, when the baby's born, you'll probably find it's covered with vernix caseosa, which is a creamy sort of material. It looks like face cream, and indeed some of the expensive face creams, they say, are made from this vernix. Now, this has covered the baby for the 9 months it's been living in a watery medium, and it's protected the baby's skin, and some of the vernix will still be on the baby after it's born. So we will move you around into the delivery room in just a few minutes. Righto, now just let your legs flop apart. We're just going to break your waters. Just draw your legs up. Just break the membranes. Not going to hurt you. It'll be cold. They always keep it in the refrigerator. Not really. Just a second. Just a minute. We're away. Cervix is 1.5 centimetres dilated. Comes away a cold cream back. Head's just above. Right, that's your water's running away there now. You can feel it.
It's hotter than your tooth.
It's hot. Mm. Now, shortly you'll be getting some contractions. How close are the contractions getting? Well,
3 minutes. You
3
turned
minutes,
it up,
yeah.
And I'm coming in 3 minutes. And, yeah, getting a bit stronger. Now.
getting a bit stronger, huh? Right. What sounds? Just. And they're going very well. 140. Well now, Mrs. P, you're fully dilated. Now, give a push, dear. Will you push down? You're ready to push. It's fully dilated now. Just push down. Push down hard. Push down. Put your hand to your knees and give a push, eh? Push down. That's it. That's it. Big breath and push down. We can see the baby's head. That's it. Right, well, with the next contraction, big breath, hands behind your knees and push down hard. We'll see if you can. Wait the contraction coming. Our friend Mrs. P suffered from some nausea late in her labour. This is a sign that the birth of the baby is imminent, and indeed many women vomit within a few minutes of their baby's being born, and again it is possibly due to pressure of the baby on the intestine of the mother, so that vomiting in the very late stages of pregnancy is very common. Mrs. P's birth was, like the vast majority of labours and deliveries, perfectly normal. Now the mother has had her baby. What are some of the things ahead of her? How long will she be in hospital? Most hospital stays average about 7 days. Some women feel that they'd like to leave hospital earlier than this, and indeed are fit and well to go. A woman having her first baby will usually require a little longer in hospital, up to 7 days, because it takes her perhaps a little longer to become accustomed to her baby, to handling the baby, to feeding the baby, and she's not had the experience of someone who's had one or more children previously, so she's a little slower in learning how to manage her baby. While she's in hospital, she will have many visitors. It is a good idea that there not be too many visitors in the first 2 days after the baby is born. The visitors in this period should be confined to her husband and immediate relatives. Later on, of course, she will have many more visitors, and this is perfectly acceptable. She will have some discharge, known as a lochial discharge, for some weeks after the baby's born. At first, this discharge is bright red, then it becomes brownish in colour, and then it changes to a yellow colour. Many women suffer from what is known as after pains, and these, surprisingly enough, are more severe at the time that the baby feeds from the breast. This is because when the baby is feeding, the mother secretes hormones which cause the uterus to go back to its pre-pregnant size. So the uterus undergoes contractions, and these contractions are like miniature labour pains, and they are occurring whilst the uterus is contracting as it goes back to its pre-pregnant size. These are often severe and often require some medication for pain relief. They're more common in women who've had more than one baby. But fortunately they're not too severe, and they don't last terribly long. Breast engorgement may occur on the 3rd day after the baby's born, because this is the time that the breasts start to fill up. It doesn't last long. Once the baby starts to drink more milk, the breast engorgement disappears. It depends, of course, on how much milk the mother has and how much the baby takes. But breast engorgement doesn't occur, as a rule, till the 2nd or 3rd day after the birth of the baby. Before the milk starts to be secreted by the breasts, a yellow fluid comes from the breast, and this is known as colostrum. It is very valuable because it carries antibodies to various diseases which the mother may have had in her earlier life. And colostrum does give the baby some immunity to various infectious diseases, so that although it is not as nutritious as breast milk, which comes about the 3rd day, the colostrum is important because it gives the baby some antibodies. Some of the discomforts in the first few days after having a baby are often associated with the bowel. Many women suffer from constipation in the first few days after the baby is born, and indeed in some the constipation is quite severe. may require the use of various preparations to soften the faeces. The bladder sometimes causes discomfort because the woman may have frequency of passing her urine and sometimes a little discomfort when she voids. However, if it is very painful and stings when she micturates, she should report this to her nurse or doctor because it may mean that she has a bladder infection, and it's important that this is treated with antibiotics because this is the only way that relief will be given. There is a phrase in maternity hospitals, the third day blues, and this refers to the depression that some women get as a normal complication of having a baby. They've been excited for 9 months, they've been very happy, they've been excited during labour, and they're excited after the birth of their baby, and they're on top of the world for the first 2 days, and then on the third day they become depressed. Now this is common. It's something which the majority of women do experience. It lasts only a matter of a few days, and it certainly has no sinister connotations. But depression on the third day is something which must be looked on as a normal variation of the puerperium. The puerperium is the 6 weeks interval which follows the birth of the baby, during which time the uterus goes back to the non-pregnant size and shape, that lactation is established, and the mother's figure goes back to the non-pregnant size. Whilst the woman is in hospital after having had her baby, she will be visited by the physiotherapist and given postnatal exercises. These exercises are extremely important because they do help the mother to regain the tone of her abdominal muscles and thus help her to regain her non-pregnant figure. It is important to do your exercises whilst you're in hospital and indeed after you leave hospital, because the physiotherapist will teach you the appropriate exercises, and it is most important that you do these not only for the week that you're in hospital but for many months after the baby is born. Many hospitals practice rooming in, which simply means that the baby stays in the room with the mother during the daylight hours and is usually taken to a separate nursery at night so the mother can get some sleep. In some cases, the baby stays with the mother for the full 24 hours of the day, and if the mother is in a room by herself, this is perfectly all right. But if, of course, she is sharing accommodation with other women, then the babies cannot be left in because it is not fair to the other women in the room. Rooming in means that the baby is with the mother all of the day, but it is taken to a nursery for part of the night so that the mother can have adequate sleep. The majority of women prefer to breastfeed their babies. However, some women, through no fault of their own, are unable to achieve lactation, so their babies have to be artificially fed. Other women, because they have other commitments at home or want to resume their work, do not want to breastfeed their babies, and they decide to artificially feed their baby. If they have adequate milk, they may have to have some medication to suppress the lactation. This can be given in the form of an injection or in the form of tablets. However, if nature has provided you with an adequate milk supply or even a plentiful milk supply in some cases, Even the miracles of modern medicine find it difficult to dry this up. So that if you have no desire to breastfeed and you've got a lot of milk in your breasts and you're given a preparation to stop your lactation, you will most likely experience some pain and discomfort. Don't think that one injection or a course of tablets will take away your milk supply without causing you some discomfort. It is not the medication which causes the discomfort, it is the breasts themselves which are full of milk, which is not being utilised by the baby, and it causes discomfort. Circumcision has received a lot of publicity in recent years. Whether a male baby should be circumcised, a lot depends upon the culture and background of the parents. Some European cultures do not agree with circumcision. Others feel that circumcision is essential, so that the decision as to whether to have your baby boy circumcised is one which must be made by the parents themselves. You can ask the advice of your doctor. Certainly it is much easier for the baby to be circumcised if it is necessary within the first few days of birth rather than later on, and this factor may be one which has to be considered. The mother will usually leave hospital about the 7th day after her baby is born, and this is a joyous occasion for both parents and any other children that there may be in the family. It is very joyous for the husband to bring his wife a new baby home, and of course if they have other children, it is a great joy to have mother home again, and particularly have the new baby at home. It's a time that she should avoid having too many visitors for the first few days until she's settled in at home, because she will feel obliged to be making cups of tea or cooking cakes to entertain her visitors when she should be resting and devoting herself to her newborn babe. Many babies suffer from colic, infant colic, and these are babies which usually do extremely well. They gain weight rapidly, they're hungry babies, and they drink their milk rapidly, and they do get severe pains in their tummy after they've been fed. It is said by some authorities that infant colic is much worse after the evening feeds. This is because the mother is attending to her husband, perhaps other children, and is not giving the baby full attention, and the baby sucks rapidly and then suffers from infant colic. If the baby has colic, it will draw its legs up and cry with pain, and this pain may last some hours. And it's not only painful for the baby, but it is very distressing for the mother. There are preparations which can ease the colic and ease the pain of the baby, but these must be prescribed by your doctor. When the baby is about 6 weeks old, it will be time to attend your doctor for a postnatal examination. He will determine whether your uterus has gone back to its normal size. He will determine if you've had any complications of pregnancy, if these have now gone, and he will probably perform a Papa Nicolau smear to see that the cervix is healthy. He may wish to also examine your baby on this occasion, although all babies are very carefully examined shortly after birth to see if they have any obvious deformities, but he may wish to see the baby at the 6-week visit to see how it is gaining weight and how its general health is. Menstruation does not recommence for some months after the baby is born. If the mother breastfeeds, menstruation may not recommence until after she finishes breastfeeding, or she may have some very irregular periods while she is actually breastfeeding. If she doesn't breastfeed, her periods will recommence anything from 6 to 8 weeks after the baby's birth. The postnatal visit is an appropriate time to discuss with your doctor family planning measures. It is physiologically impossible to become pregnant under 6 weeks from the time of birth of your baby. If you wish to have intercourse before you go to the doctor for your 6-weekly checkup, it is perfectly all right. But of course, if you've had stitches in your vagina or perineum, it may be painful. But it is impossible to become pregnant under 6 weeks following the birth of a baby. When you are discussing contraceptive measures with your doctor, the things that he will discuss are the contraceptive pill. There is a low-dose pill which can be taken while you're actually breastfeeding. This pill affects the consistency of the mucus in your cervix and thus prevents sperm invasion. It is possible to become pregnant whilst you are breastfeeding, although less likely than if you are not breastfeeding. But if you take the low-dose contraceptive pill while you're breastfeeding, it will prevent you from becoming pregnant. After you cease breastfeeding, or indeed if you're not breastfeeding, you will need one of the regular contraceptive pills, which do contain a combination of estrogens and progesterone. These pills, of course, have often been taken by you before you had your baby, and it is all right for you to take them after you have finished breastfeeding. If you take them before you actually finish breastfeeding, they may cause your milk supply to dry up simply by the effects of the hormones on your breasts. If you do not desire to take the oral contraceptive tablet, there are other methods of contraception. The intrauterine device is commonly used these days. However, it's not advisable to be used by women who suffer from heavy menstrual periods. But if your menses are light, you may consider using an intrauterine device. There are various devices, some made of plastics, others with plastic coated with copper, and your doctor will discuss the intrauterine device with you if you consider using it as a contraceptive measure. Of course, there are rubber diaphragms put in the vagina before you have intercourse and left there for some 12 hours after intercourse. There are chemical contraceptives which are used in the vagina before intercourse, and these measures will be discussed with you by your doctor. There are various methods of contraception. Certainly the pill is the most widely used, and it is a very safe method of family planning, but there are other methods which are perhaps not quite as effective, but certainly very effective methods of birth control. Although your doctor will probably take a cancer smear at the time of your postnatal visit, he will then discuss with you when you should have another smear taken, probably in about 12 months from that time. But it is important to know if you've had a smear taken at the time of your postnatal visit and when he would like to see you for another cancer smear. Foundation 41 is a research organisation set up in 1971 to look into the causes of physical deformities and mental retardation in children. As I said earlier on this record, some children are born with physical deformities. And unfortunately, when children are taken along by their parents to enrol in school at the age of 5, some 5%, or 1 in every 20, are found to have some degree of mental retardation. Fortunately, not all of these 5% of children have severe mental retardation, but they are retarded, so that school for them will be difficult. Why do these things happen? Why are the children of healthy parents either afflicted by physical or mental handicaps? This is something that we don't know even in the year 1977. So that Foundation 41 was set up to carry out research into the causes of these disabilities in children. How do we carry out this research? We do now have the details of many thousands of women's pregnancies on computer tape. We have the details of the illnesses that they may have contracted during pregnancy, what drugs they were given during pregnancy, how much they smoked during pregnancy, how long was their labour, how long did it take the baby to breathe and cry after its birth, how long did it take the baby to establish a normal feeding pattern after birth. These things all go down on computer. Then, when the children are about the age of 5 years, if we are studying some particular problem, such as some disease complicating pregnancy, we get from our computer the names of the women who had these complications in pregnancy. But we also get the names of an equal number of women who did not have these complications, so that their children can act as controls for our studies. In this way, we hope to find which complications of a woman's pregnancy may have an adverse effect upon the child.